Hello there, I've got some revision slides for the July upcoming MRCOG Part 2 exam. I hope you'll find these really useful, and if you do, don't forget to give it a thumbs up and also subscribe to the channel if you haven't already. So the target blood glucose levels that's recommended for pregnancy is fasting levels of 5.3 millimoles per litre and 1 hour after meal 7.8 millimoles per litre, or 2 hours after meal 6.4 millimoles per litre. Refer pregnant women with diabetes to a nephrologist if they have a serum creatinine of 120 micromoles per litre or more, urinary albumin creatinine ratio of greater than 30 milligrams in millimoles, or total protein excretion exceeds 0.5 grams a day. Offer fasting plasma glucose test 6 to 13 weeks after birth to exclude diabetes in women who have had gestational diabetes in the pregnancy. After 13 weeks, offer a fasting plasma glucose test or HbA1c. So very, very important differentiation, and it's important to know the difference. Very easy EMQs have come up previously on these on this sort of differentiation on this topic. Postnatally for gestational hypertension, the follow-up is daily for the first 2 days after birth, and then it's at least once between day 3 and day 5 after birth. So this is for gestational hypertension, so women who've developed high blood pressure in the pregnancy. So you'll find me jumping from topic to topic, but what I'm trying to do is cover lots of different topics and important points, so just to jog your memory for the exam. So this is clinical criteria for choice of critical care. So as you know, in the UK, you have 3 levels of critical care. So level 1, level 2, level 3. So level 3 is the highest or the most severe, as you can say. So severe preeclampsia and needing ventilation goes to level 3 care. Level 2 is stepped down from level 3 or severe preeclampsia with any of the following complications: so eclampsia, HELLP syndrome, hemorrhage, hyperkalemia, severe oliguria, coagulation support, intravenous antihypertensive treatment, initial stabilization of severe hypertension, evidence of cardiac failure, abnormal neurology. Level 1 care is preeclampsia with hypertension, ongoing conservative antenatal management of severe preterm hypertension, step down treatment after the birth. So likelihood of recurrence of hypertensive disorders of pregnancy. So if there has been any hypertension in the pregnancy, any hypertension in previous or current pregnancy, the risk is approximately 21%, is 1 in 5. If there is preeclampsia in previous or current pregnancy, risk of having hypertension is then approximately 20%. If there has been gestational hypertension in previous or current pregnancy, then the risk of having hypertension in this pregnancy is approximately 22%. Very important to note here that if you have the severe end of preeclampsia, so if you look on here where it says that if birth was if birth was at 28 to 34 weeks, approximately there is 33% chance of having preeclampsia in the current pregnancy. So just a very useful table to go through. Know the percentages really, really well, because again, this is something that would come up and it's easy marks for you to remember. Cardiovascular risk in women who have had a hypertensive disorder of pregnancy, again, quite important to note. So just go through this table in your time and just know that increases risk of all sorts of cardiac disorders, hypertension, stroke, cardiovascular mortality, major cardiovascular event. Semen analysis, so the WHO, which is World Health Organization, recommends the following reference values. So semen volume of 1.5 mils or more, pH 7.2 or more, sperm concentration 15 million spermatozoa per mil or more, total sperm number 39 million spermatozoa per ejaculate or more, total motility, percentage of progressive motility and non-progressive motility, so 40% or more motile or 32% or more with progressive motility, vitality 58% or more, live spermatozoa, sperm morphology, so percentage of normal forms is 4% or more. WHO classification of ovulation disorders, it divides it into 3 groups. So group 1 is hypothalamic pituitary failures, as hypothalamic amenorrhea or hypogonadotrophic hypogonadism. Group 2 is hypothalamic pituitary ovarian dysfunction, and group 3 is ovarian failure. So WHO group 2 anovulator disorders can be treated with one of the following, so clomiphene citrate or metformin or a combination of the above. WHO group 3 disorders who are resistant to clomiphene can be treated with laparoscopic ovarian drilling or combined treatment with clomiphene and metformin if not already offered as first line, or gonadotrophins. Now, one thing I found when I sat my exam was I didn't really go through the fertility guidelines that well, and I really regretted that in the exam because lots of questions came up on what would you, so there were lots of scenarios like, okay, a patient is, this is the result of the for the female and for the male, and what would you offer them, and they had lots of different abnormalities and so forth. So it's important to know where you'd offer what sort of treatment. So for example, this slide says indication for treatment by ICSI, so that's intracytoplasmic sperm injections. These are the reasons where you may use ICSI. So that's severe deficits in semen quality, obstructive azoospermia, or non-obstructive azoospermia. Indications for donor insemination: obstructive azoospermia, non-obstructive azoospermia, severe deficits in semen quality in couples who do not wish to undergo ICSI. Okay, donor insemination. Donor insemination can also be used when there is high risk of transmitting a genetic disorder to the offspring, when there's high risk of transmitting infectious disease to the offspring, or women from the man, severe rhesus isoimmunization. Indications for oocyte donation: so premature ovarian failure, gonadal dysgenesis, including Turner syndrome, bilateral oophorectomy, ovarian failure following chemotherapy or radiotherapy, certain cases of IVF treatment failure. Right, so this brings us on to the intrapartum care guideline, which I will be summarizing as well separately because I do think that guideline is very important, and lots of things come up from that guideline that we generally tend to ignore, but can be quite useful for the exam. So I will be summarizing that separately as well. Now this table here says primary reason for transfer to an obstetric unit, number of women transferred from home, number of women transferred from a freestanding midwifery unit, number of women transferred from an alongside midwifery unit. So you have delay during first or second stage of labor, abnormal fetal heart rate, request for regional analgesia, meconium staining, retained placenta, repair of perineal trauma, neonatal concerns, and others. So you can see the percentages of transfer from different units to the hospital. Again, something quite useful to have in the background for the exam. So latent first stage of labor is defined when there is painful contractions and some cervical change. So there is some cervical effacement and there is dilatation up to 4 centimeters. Established first stage of labor is when there is regular painful contractions and there's progressive cervical dilatation from 4 centimeters. So first stage of labor varies between women. When it's first labor, It can normally last on average of 8 hours. It's unlikely to last over 18 hours. Second and subsequent labors last on average 5 hours, unlikely to last over 12 hours. Prolonged third stage is third stage when it's not completed within 30 minutes of birth with active management, or within 60 minutes of birth with physiological management. So active management is where you give patient a drug, and either syntocin or sintometrin or ergometrin, whatever different hospitals use, but you're giving an injection to allow the placenta to come away. Physiological is where you're just waiting for the body to do it all itself. So active management, nausea and vomiting is about 100 in 1,000. 13 in 1,000 is a risk of hemorrhage over a liter. 14 in 1,000 risk of having a blood transfusion. So if you've given the injection, these are the figures that you need to know for any problems. With physiological management, nausea and vomiting is lower, naturally, because you're not giving a drug, 15 in 1,000. However, hemorrhage is 29 in 1,000 of more than a litre, and blood transfusion risk is about 40 in 1,000 for blood transfusion. Active management is where we said we administer 10 units of oxytocin by intramuscular injection with the birth of the anterior shoulder of the baby, or immediately after birth of the baby and before the cord is clamped and cut. So first degree tear is where it's injury to the skin only. Second degree is injury to the perineal muscles, but not to the anal sphincter. Third degree is injury to the perineum, involving the anal sphincters at 3A is less than 50%, 3B is more than 50% of external anal sphincter, 3C is internal anal sphincter tone. Fourth degree tear is injury to the perineum involving the anal sphincter complex and the anal epithelium. Amniocentesis should be performed after 15 weeks of gestation. CVS should not be performed before 10 weeks of gestation. Okay, so gestational pruritus is where it's itching and peak bile acid concentrations is less than 19. Mild intrahepatic cholestasis of pregnancy is where it's itching and raised peak bile acids between 19 and 36. Moderate is between 40 and 99, and severe is over 100 micromoles per liter. For complete molar pregnancy, if beta-HCG has reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from the date of the uterine removal. If beta-HCG has not reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from normalization of the HCG level. Follow-up for partial molar pregnancy is concluded once the HCG has returned to normal on 2 samples at least 4 weeks apart. So low-lying placenta, that's placenta that's less than 20 millimeters from the internal os, or previa that's covering the os. At the routine fetal anomaly scan, if this is picked up, then a follow-up transvaginal ultrasound is requested at 32 weeks to diagnose persistent low-lying placenta and or previa. Persistent low-lying placenta or placenta previa at 32 weeks of gestation, and patients who remain asymptomatic should have an additional transvaginal scan at 36 weeks to inform discussion about mode of delivery. Placenta previa is where the placenta lies directly over the internal os. Low-lying placenta is where the placental edge is less than 20 millimeters from the internal os on the transabdominal or transvaginal scan. In the absence of risk factors with placenta creta, planned delivery should take place between 35 and 36 plus 6 weeks. This is a happy medium for keeping in mind prematurity, and then also the likelihood of the women going into labor and then presenting with bleeding and emergencies, because that's not what you want for placenta creta spectrum to come in hosing or hemorrhaging out of hours. So this is a happy medium between 35 and 36 plus 6 weeks. Well, that's it for now. If you found this video useful, then don't forget to hit the like button and subscribe to the channel if you haven't already. Also, I'll be doing lots of helpful videos like that on revision of different TOG articles before the upcoming exams and throughout the year as well. Is there anything in particular you'd like me to cover? Then please do let me know in the comments section. Thanks for listening.